All right. Well, welcome everyone. We are happy that you're here as we talk about applying ORP and digital sleep analytics in clinical care with Dr. Magdy Younes, co-hosted by Cerebra and the Center for Sleep and Human Performance. My name is Dr. Amy Bender. I'm the Director of Clinical Sleep Science at Cerebra. Thank you for joining us. Let's go ahead and get started. So how the rounds work, I just wanted to put a few bullet points here so you have some background on how this round works. If this is your first time, Dr. Younes will present a new way of looking at sleep architecture using ORP. He's going to apply this approach to difficult cases provided by Center for Sleep and Human Performance. And for this round in particular, we were actually able to get a special cohort of idiopathic hypersomnolence patients from Dr. Thomas from Beth Israel Deaconess Medical Center. So Dr. Younes is going to talk about that more as he presents. We will have about 10 minutes at the end for questions, so make sure you use the Q&A function here in Zoom. And then after the rounds, we will send out an evaluation for feedback. So we definitely want to hear from you if you have maybe future case examples or topic areas that you want us to cover. So I wanted to introduce our speakers for today. Dr. Charles Samuels is the medical director of the Center for Sleep and Human Performance and holds an adjunct assistant professorship in the faculties of medicine and kinesiology at the University of Calgary. He is past president of the Canadian Sleep Society and has a clinical background in rural and urban family medicine. He has acted as a primary and co-investigator on over 20 clinical trials and served as the vice chair of the Research Ethics Review Committee of the College of Physicians and Surgeons of Alberta. He has numerous peer-reviewed publications and is a well-respected medical educator who speaks internationally on topics related to sleep health and performance. Dr. Younes is a distinguished professor emeritus at the University of Manitoba. He has been a clinician, scientist, university professor at McGill University, University of Texas Medical Branch, and University of Manitoba, where he served as the head of respiratory medicine. Dr. Younes's research in respirology, critical care medicine, and sleep medicine has resulted in over 162 original peer-reviewed papers, 22 book chapters and reviews, and numerous patents. Dr. Younes is the inventor of Michelle Sleep Scoring, the Prodigy Sleep Monitor, and the Odds Ratio product, the star of the show today. And we are just very grateful to have our speakers here for all their experience and expertise, and just hoping that all of us can learn something new today. So I'll pass it over to Dr. Samuels, who's going to introduce the topic for today.
Thanks, Amy, and it's always fun and good to see you, Magdy. So I think today is really interesting because it's the application of ORP to clinical cases of idiopathic hypersomnia. And so that's a really unique application. And Magdy and Robert Thomas have worked on quite a number of cases, and they have a case series that really helps to build out our understanding of ORP and how it can discriminate some of the patients who present to us who we clinically suspect have IH, then we put into the lab. The standard approach in the case that Magdy will demonstrate from the Center for Sleep is sort of a typical sleep study of, doing a nocturnal polysomnogram followed by MSLT, whereas Robert at Harvard tends to let the patient sleep continuously as long as they need to. So these are very unique and different ways of looking at it. And having the ORP as an analytic tool or probe, of course, in my view, because I support this, technique, is really clinically very valuable. So I'm going to turn it over to Magdy and let her rip.
Okay. Oops. This. Okay, can you hear me?
We can hear you and we can see your screen if you want to make it full screen.
Yeah. All right. So how ORP can help us better diagnose idiopathic hypersomnia? I used to start with the topic of the day, but we got real complaints, that people wanted an introduction first because many people just joined the webinar for the first time. So I will today start again with a general introduction about ORP, what it is, and so on. So by popular demand, for those of you who have seen it 3 times or 4 times already, I apologize. What is ORP? ORP is a continuous index of sleep depth. So rather than saying awake stage 1, stage 2, stage 3, and so on, it is a continuous index that starts at 0 and ends at 2.5. So 0 is very, very deep sleep. 2.5 is fully awake. And in between, just to break it into brackets, we have this table for you. 0 to 0.25 is very deep sleep. 0.25 to 0.5 is deep sleep. 0.5 to 0.75 is moderately deep sleep. Up to 1 is light sleep. After 1 is not really, it's neither here nor there. Between 1 and 1.75, it's epochs that have both wake and sleep features. And then at 1.75, that's usually when technologists score the epoch as awake. But because this is a continuous index, we have different grades of awake. Very drowsy awake. Between 2 and 2.5 is drowsy awake, and above 2.25 is fully awake. So just to show you again the green rectangle, this range is what usually is scored 95, 98%, scored by a consensus of technicians as sleep, but they don't say, of course, what is the depth of sleep. 1 to 1.75 is transitional sleep. Usually the texts get split here in this range. Some would call it awake, some would call it asleep. And these 3 ranges then are usually called awake. So why do we need a continuous new index of sleep depth? What's that? Why do we need a continuous index? Well, it's because the conventional metrics are seriously flawed. So let's look at these 2 examples. So these are 4 epochs, all of which, as you could agree, are scored as awake. But they're obviously very different from each other. The top one is wall-to-wall beta, high amplitude beta. The next one, we can see that the amplitude of the beta is less, and we're beginning to see some slower rhythms. In the third one, there is more slower rhythms, but it still looks awake. In the fourth one, it looks awake at the beginning and at the end, and in between we have a micro sleep, but it doesn't measure up to 15 seconds. So it's still called awake. So you can appreciate that we have different levels of awake. And the ORP tells us that this is the maximum. And then by the time it's going to be about sleep, it's down to 1.69 or so. And so what is important about this is that it's turning out through clinical trials that people who spend a lot of time in drowsy awake, they are actually sleepy during the day. So the lower the ORP during stage wake, the more likely the patient is to be objectively sleepy. Whereas the more time the patient spends in full wakefulness, that generally indicates a hyperarousal state. The second panel here is the opposite. This is different levels of sleep depth in stage N2. The top 5 panels are all called stage 2, just because they have spindles. But you can again see the difference in the way they look. This one looks awake and with a little bit of theta. Were it not for these arousals, for these spindles, we would call it stage awake. And as you go down, you see it departs more from the wake pattern into the very deep sleep pattern. And next step is stage 3. So the patient may spend 5 hours in stage 2, but you wouldn't know whether it's terrible sleep like this, like almost awake, or very deep sleep like stage 3, but it just doesn't have 6 seconds of delta sleep. So this is really the main distinction between using ORP to classify sleep versus the conventional RNK stages. Was this validated? And I mean, I can assure you that it was validated. There are many papers that validated it, but the main one, the most compelling validation is the relation between current ORP, like right now, and how likely is the patient to get an arousal or awakening in the next epoch. So this came out in the first paper, and it shows the top here is the number of 30-second epochs. So in this group of patients, we had 88,200 30-second epochs in this range in the first decile between 0 and 0.25. And looking then at the next epoch, only 9% of them had arousals. And as the current epoch ORP increases, you can see that the probability of arousal increases until you get to 2, which is almost certainly you're going to get an arousal in the next epoch. So that shows a perfectly linear, not perfectly, but a good linear relationship between ORP and how deep sleep is. So that is the validation that when we say ORP is high, it means that your sleep is light. If you say ORP is low, it means your sleep is deep. How is it measured? I don't know if you want to get these details, but some may be interested in that. So we start with 3-second epochs, just like this one, has the wiggle like this. And the first thing we put it through what's called Fourier transform to break it down into its constituent waveforms. So we have 4 ranges of waveforms: the big delta waves, the theta waves, which are next in frequency, the alpha sigma waves, and then the beta, which are the highest frequency. So the first thing we do with Fourier is to determine the power in each of these 4 different ranges. So in this particular 3-second epoch, we got these numbers. So how do we go from here then to ORP? Okay, so we have a bank of data with 4, that's how we did it. We haven't really changed it. We haven't changed the reference values for ORP, but we had 430,000 3-second epochs. They had the whole range of delta power and theta power and so on. So we ordered them from the highest to the lowest, from the lowest to the highest delta power. So that would be the minimum value, and that would be the maximum value. We do the same thing for theta, for alpha, sigma, and beta. And then we break each range into 10 deciles. So the lowest 10% of each of these is given the rank 0, and the next lowest is given the rank 1, and the highest 10% of the whole range is given the rank 9. So now let's see where that epoch fits. So we say, where does delta fit? Where is 202 in this scale? So it turns out that it is near the highest range of delta. Where is theta? It ends up being in the middle. Where is alpha? It's very, very little alpha and hardly any beta. So 8410 is the number we give to this particular 3-second epoch, and we do that for every 3-second epoch. So by just looking at the number, you can say this epoch has a lot of delta, a middle of the road theta, and very little alpha and beta. And then how do we go from this number to ORP? So you realize that we have 4 categories. Each one has 10 scales. So we have 10 to the power 4, or 10,000 numbers. So every 3-second epoch will have one of 10,000 numbers. So here is the spectrum. It goes from 0 to 9999. So, you know, it's 10,000, but I couldn't put the more there. So for every one, then we find out how many of the 0000 in the data in the reference bank were there. And in this case, it turned out to be 4,000. How many of these occurred when the subject was scored awake or in the middle of an arousal? So it turned out to be 1,700. So what is the percent of this bin number that occurs during awake and arousals? And here it's 48%. And we do the same thing for every one of the 10,000, and we end up then with a probability of this particular pattern occurring during wakefulness or during arousals. And I had an employee who happened to be my son. He didn't like percent. He said it's too mundane and too common. So let's divide everything by 40. Okay, 40, and so now the ORP is the probability of the pattern happening in awake stages and arousals divided by 40. So 1 means 40, 2 means 80, and so on. It's just a gimmick, okay? I'm very embarrassed by that, but this is the way it is. We got stuck in it. So here are some examples. This is an example of 0000. There's hardly anything. And the probability, as we saw, is 37%. This is the same one, except it has a little bit of more beta. So now this is happening 71% of the time awake. And this, you know, you can see the big ones now have 9, 8. That's a lot of delta and theta and a little bit of beta. So that happens almost never awake. Whereas the same high powers of delta and theta, but have more beta, almost never happen when you're asleep. So this is the whole idea. And then we break the whole file into 3-second epochs, and we assign an ORP to each of the 3-second epochs. Okay, what is the main advantage over conventional scoring? The advantage primarily is in identifying mechanisms of patient symptoms. So let's look at this example. These are two people that have normal histograms, and I give you the numbers here so you can believe me that. So total sleep time is about 7 hours, sleep efficiency 89%, 95%, a little bit of N1 in both, a bit of N3 in both, and a bit of REM in both. Arousal index is normal. So I think you would both agree that this would be called normal sleep study, and if you have symptoms, it's all in your head, and you know, go consult a shrink. So now we're going to remove the rectangles that hide the ORP, and now you can see that these two patients are completely different. This is the ORP scale here, and you can see that this patient with a normal conventional hypnogram is spending most of his time in the mid-range, which is transitional, and only very little time in deep sleep. Whereas this patient is spending most of his time in deep sleep with very little transitional and awake. Now we can't, this is just a picture, we can't really report it in the report, so we have to somehow systematize the reporting of this. So we can make measurements like that. ORP awake, so we take all the awake epochs and get the average ORP, all the non-REM epochs, all the REM epochs. And so these are the averages of the different conventional stages. And this patient has 2.241. This other patient, look at the difference. He has lower ORP awake, which means he's more sleepy. He has much lower ORP non-REM, which means his non-REM sleep is much deeper. Remember, 1.34 is transitional level of sleep, whereas 0.4 is very deep sleep. So that's telling us this patient's having very deep sleep, even though they have the same amount of N2. ORP REM is much lower too, so that when they are dreaming, they're in deep sleep. This one, when he's dreaming, is in light sleep. And that's ORP across the whole PSG. Transitional here, very low and good. So you can tell right away that despite the two similar conventional hypnograms, the ORP tells us they are very different patients. Okay, numbers are a bit confusing. So there is another way of expressing it, which is actually, they say a picture is worth 1,000 words or 1,000 numbers. So we can report it like this. This is now the ORP histogram, which is a new phenomenon in sleep medicine, where we say how many epochs were in decile 1, which is between 0 and 0.25. In this patient, there was only 1%. How many were in decile 2, and so on? And this is 10, which is full wakefulness. And we do the same for this patient. Again, you can see that picture-wise, you can really tell these are two different people. And now we know that this is a specific pattern that describes some underlying pathophysiology. The brain cannot get into deep sleep, and as a result, the patient is sleepy. You can see that most of his awake time is in drowsy sleep with very little full wakefulness. On the other hand, this patient spends most of his time in very deep and deep sleep with hardly any transitional or wake stage. So this patient has one disorder, this patient has another disorder. This one indicates the patient has very strong sleep drive, whereas this one says the brain can't get you into deep sleep for whatever reason, and as a result, you are sleep deprived. This one doesn't have a lot of full wakefulness, which means you could also be sleep deprived. So this pattern is typical for people with idiopathic hypersomnia. And you can see it also in some very young people because they have very deep sleep. But when you see it in older people, it usually means they're sleep deprived, either because they were sleep deprived before, or they currently have hypersomnia. So this is the main difference between ORP and conventional scoring. Now, we can do even better than that. I mean, we can't really describe it. What are we going to say? This is a pyramid, and this is a Texas boot, or, you know, it's not really very scientific. So we decided to make some types, call them types. So this one is called type 1, and this one is called type 3-1. Why are we calling them this? It is all based on the relation between how much deep sleep they have versus how much full wakefulness. So deep sleep in this patient is 7%, which is the sum of these two, and full wakefulness is only 2.5%. So that's why it's called 1-1, because deep sleep is in the lowest quartile of community dwellers. And this one here means this is in the lowest quartile of community dwellers. This patient has 66% of total recording time in deep sleep. This is in the upper quartile of community dwellers, so we call it the third one, number 3. Full wakefulness is also low, so we call it 3-1. So you can imagine that you have 1-1, 1-2, 1-3, and so on. So we basically have 9 patterns. This is 1-1, very low deep sleep and very low full wakefulness, very low deep sleep, 1-2, but average amount of full wakefulness, very low deep sleep, but a lot of full wakefulness. So we call that 1-3. And then this is 2-1, 2-2, 2-3. 3-1 is our baby here, a lot of deep sleep with very little wakefulness. And here we have 3-3, which means the patient has a lot of deep sleep, but also has a lot of full wakefulness. And there is a paper down here that describes what is the meaning of EOS, what theoretically is the underlying mechanism for these different patterns, and they would call for different treatments, which are currently all under investigation. So, but these are the 9 patterns and how you can interpret the 2-digit number. And this table, which is in this paper, describes these are the 9 patterns, the potential mechanisms for this pattern, what the clinical associations are, and what are the suggested clinical implications. I'm not going to go through that, but anyone interested. So it just shows you that these different patterns are associated with different things and they mean different things. Okay, now how can ORP help identify the mechanisms of idiopathic hypersomnia? And I want to introduce you now to the concept of cumulative sleep index. Typically, when we say how much sleep did the patient have, we say, you know, total sleep time is so much, and so on. So here are 3 patients that have normal total sleep time and sleep efficiency and arousal index. All 3 of them have fairly normal things. But when we look at their ORP, you can again see this one has a lot of deep sleep. This one has moderate sleep, and this one has very poor sleep. And so the CSI is a number. It is not time, and it's not depth of sleep. It's a combination of the two. So it is the integration of time across the sleep, across the night, and how different ORP is from full wakefulness. So it's basically the integral of this white section between the black line and here, of course, because we have, you know, like in this epoch, ORP may be 0.5. It's 2 points below 2.5. So for this particular epoch, we have a difference of 2 multiplied by 1 epoch. And so if we multiply it by 800 epochs, which is 400 minutes, we get 818. And not 818, this is the integration of all, 818 is the integration of all that white matter between the black line and the ORP line. The second patient has 482 only. That's only 60% of this patient. This one has 253, which is a third of this patient. So you can see that with normal hypnograms, you can get very different sleep amounts accumulated in an 8-hour period. And this is the index we are going to use to evaluate idiopathic hypersomnia. So the first patient was provided by Dr. Samuel's lab, is a 36-year-old female with hypersomnolence. The medical history, really, there is nothing. Biometrics, BMI is normal, neck circumference is normal. She's very sleepy. And with MSLT, her sleep onset latency on five naps, less than 5 minutes, and she's not taking any meds. So, I mean, that history really suggests either idiopathic hypersomnia or something messing up her sleep. So the conventional PSG showed a normal total sleep time, normal sleep efficiency, normal sleep latency, normal REM, no AHI, normal N1, normal, everything's normal. Everything is normal. So here is the histogram, and as you might expect, it's normal. So then Chuck really likes ORP for whatever reason. So they did the ORP on her, and this is what we found. As you can see, she has almost all the time in deep sleep, except when she's in REM, which typically is higher. And she was awake a little bit here, and again in REM, it was higher than during, but during non-REM, she was in very deep sleep. There were very few arousals, no respiratory events, and no. So here now we get into the ORP values. Her ORP awake was middle of the line, which means she wasn't really that sleepy. Her non-REM ORP is 0.36. The average is about 0.8. So her non-REM sleep is very deep. REM sleep was higher, but not very high. Total sleep time across the whole night was 0.54, which is one of the lowest I've ever seen. And total recording time, again, is very low relative to average people. So all these things mean that this patient has extremely deep sleep, and yet she is very sleepy, very consistent with idiopathic hypersomnia. Her CSI was 840. The normal range was 550 to 7. So 750 is the high end of average people. She was even higher than that. So that suggests that this patient has excessive need for sleep, which is the, what everybody thinks is idiopathic hypersomnia. So this is a classic case. And if we look at her histogram, she is type 3-1 with most of her time in deep sleep and very little in the lighter sleep and transitional, and very little full wakefulness. Full wakefulness, when you see awake here, that doesn't necessarily mean full wakefulness. You can see that ORP here can be very high or very low during awake periods. So this is the patient, and that is the end of the story. So this is one spectrum of idiopathic hypersomnia, which really goes along with what we think of idiopathic hypersomnia. But this is not the whole story. Idiopathic hypersomnia, as we found out working with Dr. Robert Thomas, is really covers a very, very wide range. And in a single sleep lab, it's difficult to see all that range. So that's why this time we're changing routine. And rather than presenting more and more cases, we're going to go directly to a study that we did together with Dr. Thomas. Dr. Thomas is at Harvard University, as Amy said, and we presented that at the APSS meeting last June. So he is different from other sleep doctors in that he really likes idiopathic hypersomnia, and he's got a special protocol for these patients. He lets them sleep after Chuck said that he lets them sleep after the regular 8-hour study as long as they want, even until next evening. So he's accumulated quite a few patients like this, and he suggested at one time, why don't we do ORP on them and see what we get? He sent me 36 files, and this is what happened during the sleep study. The total recording ranged from 620 minutes to 950, which is 10 hours to 16 hours, with an average of 77, which is 12.8 hours. That's when you let them sleep. The total sleep time ranged from 5 hours to, I don't know what that is, here, 13 hours, with an average of 10 hours. So these are really people who, and they had, of course, no sleep apnea or anything like that. So we determined ORP across the entire total recording time, which is up here. And we calculated CSI at 8 hours, which is what they would have had if we just did a routine sleep study of 8 hours. But also we calculated CSI at the end of their sleep, which now tells us how much sleep units do they really need to feel to spontaneously wake up. So this is the protocol. And here is one type of patients. We call it quarter number 1. And I don't know why this thing. How can I take? How can I get rid of this? Oh, okay. So you can see that this patient is at 8 hours had only 278 CSI. Remember, the normal is 550 to 750. So he or she had terrible sleep in the first 8 hours. And he kept sleeping for 15 hours, accumulating 462. Now, what you notice here is that at the end of 14 hours or 15 hours, he even accumulated less than the normal person accumulates in 8 hours. So for this patient, the problem is not that he has a lot of, his brain is not, it's not that his brain doesn't wash out the waste products very quickly. that he needs more time to wash it out. He just that his sleep is terrible, so that he needs to sleep more, to stay in bed more, to get the same amount or even less than what a normal person gets. The next quarter, oops. You see, this is a higher level. So this is what, like one of the patients I showed you before, spends most of his time in transitional sleep and keeps sleeping for 14 hours. But at 8 hours, got only 532. At the end of 14 hours, he got 907. All these are patients with true idiopathic hypersomnia, as illustrated here by the fact that they can keep sleeping for another 4 to 8 hours. This is now deeper sleep. At 8 hours, he got 780, which is pretty close to the upper end of what a normal person gets. But that wasn't enough. He needed 1080. So he had to sleep another 4 hours. And the last one is the deepest one. And this is like the patient of Chuck. You know, he's got deep sleep and got 915 units in the first 8 hours and went on to get 1358. So let's just look at, this is the big picture, okay? So what we can, with clinical implications, obviously. So we can say that this patient, I'm going to go very slow here. His problem is his brain can't make deep sleep, not because of any AHI or whatever, PLMs. It's just his brain can't do that. Maybe this is, you know, this is a flaw in his sleep control system, or maybe, I don't know, but now we have to look at these patients. Some narcolepsy patients are like this. They have very poor sleep like that, but they don't get this type of pattern. As Chuck said, they tend to get sleep attacks as opposed to being very sleepy during the day. So, so this is one type of idiopathic hypersomnia. The patient has to sleep a lot more in order to get the normal amount of sleep. It's, you know, this reminded me of the fee scale of different physicians. Okay, so we can all spend 8 hours working, but GPs generate very little in the 8 hours, and ophthalmologists and radiologists generate 4 times as much, you know, in the same hour or even less. So this is the meaning of CSI. It's how much units of anything, of sleep, you generate in the same amount of time. So, but the other implication here is, although I don't have the answer, is that if this patient needs 460 units, but he can only get 280 in the first 8 hours. What if we could get the sleep deep enough that he can move to the next level and make 532? Well, of course, he's got enough. Maybe, I mean, this is all theory now. Maybe if we can deepen his sleep from this level to this level, we can cure his idiopathic hypersomnia. Again, maybe I say, and this one, if we take him from here to here, make him a lot deeper, he would be enough in 8 hours. So, and we are moving like that actually in narcolepsy by using medications that make sleep deeper and with some effect, but this is much more compelling here. But the problem here then, and I'm near the end here, is that the idiopathic hypersomnia is a wide range. In some cases, the patient needs more time in bed because his sleep is terrible in the first 8 hours. So what he needs is not very bad. It's actually very low in this, but his sleep is terrible, so he needs more hours. Or it could be he's very, very deep sleep in 8 hours, but he now really needs a lot more. So these two patients, there is nothing you can do because their sleep is very deep already. You can't make it deeper. You can never reach 1089. The most you can get is 915. So these two are going to be sleepy no matter what. But if you can raise their sleep depth from here to here, he would then need 150 less, so he would have to sleep less. This is all speculation. The other thing you need to notice here, which, like I say, this is really the whole picture, is that people who have poor sleep in the first hours have poor sleep when you let him sleep. When you have medium, it's medium. When you have deeper, it's deeper. When you have very deep, it's very deep. So it's not like, you know, these guys really need a lot of sleep. And why is it like that? I don't know, obviously, but it could possibly be some regulation issue, or it could be that the lymphatic system is not as efficient, so they don't get much washout per hour, so they need more hours. I mean, who knows? But this is a field now that is ripe for investigation. And the other thing that is relevant to treatment is, like I say, it is possible that if we deepen sleep, the amount of extra sleep they will need will be much less, or even be nothing. There will be nothing, like in this patient or this patient. The issue is, how do we get people to lower their ORP? Sleep restriction is one way of doing it, but that's okay for insomnia, not for these people. You can't restrict sleep in a patient who needs 14 hours of sleep. So, and the effect of, we studied the effect of sleep restriction on ORP. It goes down, but not, it goes down, but not much. So sleep restriction is not going to work. We have to find a drug that lowers ORP. There are many drugs that have been described that so-called are delta promoters. In other words, when you give the drug, the delta waves increase. But I looked at many of these, and many of them really, it's not a selective increase in delta. It's an overall increase in power. So delta, theta, alpha, and beta all increase at the same time. So if you're looking for delta, you'll find it high, but really it's not a specific increase in delta. And therefore the relation between slow waves and high frequency waves doesn't change, and by extension the ORP doesn't change, because ORP looks at the relative value of these four, where if you increase them all or decrease them all, ORP doesn't change. In other words, if you change the amplifier gain, you're not going to change the ORP. But so these drugs, most of them actually would not work, would not make sleep any better. But we need to look for, the only drug I know that convincingly lowers ORP to this level or even lower is propofol. Okay, but we can't really use propofol like, if you're, what's his name? I can't remember now, the fellow that died from propofol, the singer. Anyway, we can't have a propofol IV drip, overnight with the doctor standing next to you, make sure you don't die. So we need drugs then, and if pharmaceutical companies, tell them this is a multi-billion-dollar business if they want to get into it, finding the right drug that lowers ORP, okay? Because that will fix insomnia, that will fix idiopathic hypersomnia, hopefully. But this is the problem, is that most of the drugs we have, zopiclone or whatever, they don't really lower ORP. Or even the delta promoters. So I'm going to, here are the 4 histograms for these 4 people. See, this one spends most of his time in transitional and drowsy sleep rather than, and a lot of full wakefulness. This one is at the pyramid, which means the brain cannot make very deep sleep and the patient is sleepy. And these 2 are, of course, are sleep deprived people. So you can see if you have a patient with a classic history of idiopathic hypersomnia, just like Chuck's patient, but you do the histogram and it looks like this or like this, then this is really, it's primarily because of poor sleep quality. And that's what we have to work on. Whereas these ones would be consistent with the true idiopathic hypersomnia, the patient needs a lot more sleep than usual. And therefore we have to give him stimulants or figure out something else. Thank you very much. questions.
Okay, Magdy, you ready for this?
Mhm.
Okay. I'm going to leave just one sec here. Matthias has a question that doesn't talk about clinical stuff, so I'll leave it to the end. But it's important. So we have one question. If a higher CSI generally indicates better sleep quality, which I'm not sure if that's what you're saying, how do you distinguish if someone has a problem such as sleep deprivation or hypersomnia, other than a patient report, their history? Can we distinguish from people who are sleep deprived versus have hypersomnia, a condition of hypersomnia? So that would be the question.
Yeah, of course. I mean, a test is never conclusive about anything. You know, if you have a high blood sugar, it doesn't mean you have diabetes. Maybe you had an IV glucose just before the test. So you know, it's the whole package. The patient has to give you a history of hypersomnia. You need to confirm that. And then you need to know that this is not just a one on, night off. So it has to be consistent with the history, that the patient would tell you that last night's sleep in the lab was typical of my sleep, but I'm also feeling sleepy and I take lots of naps at night during the day, and on the weekends I sleep until noon or afternoon. So the whole thing, and then you find this pattern of ORP, then it all fits. But if you find an ORP that is very poor in the sleep study, then the problem is that this patient does not, I mean, he by definition, he needs more sleep, but it's not because his brain needs more sleep. It's because he needs to spend more time asleep for the brain to get restorative function of sleep. I don't know if I answered this question. Huh?
Yeah, no, I would agree. And I think that's the thing that is very, very helpful, is that it helps us discriminate between the quote unquote good sleeper who needs lots of sleep versus the person who presents with hypersomnia and actually isn't sleeping. And this is an age-old problem. I mean, you know, for the 30 years I've been doing sleep medicine, we just go, well, let's give her a shot and put them on a sedative and see if they get better. Or let's give them a stimulant and see if they get better. Well, now this is a very good indication that, oh, they have very poor sleep quality. Let's focus on that, see if it turns into a clinical benefit. And if not, we can then move on. So I think that's the distinguishing we get from what Magdy has presented with Robert's data. Matthias Basner has asked a question: are 8 hours of light sleep, oops, one sec here, the same as 4 hours of deep sleep if both calculate to the same CSI? So can you speak to that?
I didn't realize Matthias is on the webinar. Good to hear from you, Matthias. I don't know. This is the, you have the most wonderful labs in the world, so maybe you can test that with your cognitive function, but you first have to find a way to change to control this, you know, to have 4 hours of ORP 0.5 versus 8 hours of ORP 1.5. And that really is the hooker, you know. Like I say, propofol is one way to do it. You have to have a patient with poor sleep. Michael Jackson is the name I was thinking of.
You got two people to weigh in on that.
And of course, Michael Jackson died because he had a cardiologist from Philadelphia looking after him. Sorry, Matthias. So there you go. So you have to be able to control that, and propofol would be a wonderful way to do it. But that is, I don't know the answer to that. I hope it is. You know, theoretically, it makes sense that it may be that it's a quality and a quantity, but I don't know.
Okay, so this is a complicated question from Quinn Eastman, who corrected you, I think, about Michael Jackson, or offered that up.
He corrected me?
No,
was
he did
Michael
not.
Jackson.
Sorry. So no. He did not. No one corrects you, Maggie, ever. He offered up Michael Jackson as the answer.
Oh yeah, I see.
Okay, sorry. I apologize. Okay, so here's this question: how much overlap in ORP profiles do you see, which you may or may not know, between people conventionally diagnosed with type 2 narcolepsy versus idiopathic hypersomnia? My guess is you haven't done that work, but I don't know.
No, I have. I work with Fang Han from China, who has a huge collection of N1 and N2. There's really not much difference in ORP between them. I mean, it's just that one gets cataplexy, the other. I mean, it's just a description of the patient, but not the ORP. The ORP in narcolepsy also, and I hope Fang Han will write the paper. Like, we studied hundreds of people with narcolepsy, and that also, just like idiopathic hypersomnia, covers the whole range. You know, the ORP within the 8 hours of sleep can vary from very poor sleep. So there is a subgroup of narcolepsy 1 that have very poor sleep, and apparently Xyrem works for them. It works not just for the cataplexy, but it makes their sleep better. So Xyrem is another potential drug for improving sleep. It lowers ORP, like I know that. It lowers ORP, Xyrem. And so it's one of the very few drugs, that and propofol, that help lower ORP. The other ones, the Z drugs, don't lower ORP, and many of the other delta promoters just amplify the whole signal, not just so that's yeah. But maybe the question also, Dr. Eastman wanted to know how reproducible the ORP pattern is from night to night in the same patient. And that's a very, very important question. And Amy, she's the only person in the world actually who studied 20 patients for 20 consecutive nights with the ORP. Okay, and in fact, some patients have exactly the same pattern for every one of the 20 nights. Okay, and other people, they will change from night to night, but the change only one digit will change by 1, like 1 would become, some nights would have 1-2 or 2-1 or something like that, but you don't get a huge shift in the pattern. So it is, and you know, heredity studies show that most of sleep characteristics are highly heritable. So that it is possible that the ORP type is a heritable trait. And we do have the data, although we haven't really analyzed it yet with Alan Pack and company, the twin data.
So I have another question, Maggie. I think this is a really good one. Do we see a disproportionate amount of type 3-1 in younger populations due to the amount of deep sleep they might have compared to a community sample? Do you think the type? Yeah. Do you think the types would still differentiate sleep problems in this population, or would the types be less sensitive to the? No. Okay.
Very good question. No, very good question. In the paper that I cited, I wish I had the picture. It shows you exactly the frequency of different types in different ages. And very young people, you know, like high teens and, you know, low 20s, a lot of them, maybe 20% of them, 30% of them would have that pattern of 3-1. But we have to remember that many of them also work hard and so on. So they may also be sleepy. I mean, sleepiness is quite common in young people. But they do have, whereas people like my age, 95 plus, they would have less than 1% of the people would have type 3-1. So if you find type 3-1 in a 60-year-old man, this is clearly abnormal. Okay. Whereas if you find 3-1 in a 20-year-old, it's not that it is definitely not abnormal, but it's likely that it could be because he's just not sleeping enough, or
right. It indicates a problem that doesn't
maybe
indicate
lifestyle.
A pathology, right?
Yeah.
Jamie McFarland asked, Q1 to Q4, is there a theoretical more favorable response to stimulant medication in one group versus the other? Can you answer that?
This is the first description of different groups in
Right.
idiopathic hyper. It's up to you guys to find out.
Nope, and we're on it. Okay, no, that's good. From Mandeep Singh, thanks for a great presentation. In the last slide, there were the last two patients having or likely to have SOREMs, so sleep onset REMs, seen in the prolonged sleep period after 8 hours, and therefore indicative of narcolepsy. So how would you interpret that? Their REM was persisting into longer than an 8-hour sleep. So if we were studying them, we would actually, if they had two SOREMs, we would call them narcoleptic.
If you studied them for 16 hours.
No. If we did an 8-hour night and then did an MSLT.
Okay. Yeah, if you had, in other words, you had a wake period in the middle,
Yeah.
and you got REM after. Yeah, no, again, this is a fresh study. We just analyzed it to make an abstract. But this is a very good question. And what do you say? I mean, is it a sleep? How do you define sleep onset REM? Like how long does it take between when they fall asleep and the onset of REM? Is one epoch enough, or do you have to have? I mean, is 10 epochs enough, or you have to have one epoch, or what? I mean, how do you? This is new territory. I mean, how many people were studied for 16 hours?
That's the thing, is I think there's a great opportunity to look at potentially improving the diagnostic validity of polysomnography with ORP, but using longer, like allowing patients to sleep, which we don't do, right?
Right.
So it's interesting, actually. That's a really good question.
Too
Have you
bad,
talked to any neurologists about this?
No.
No.
I hope
Okay.
Robert is listening. He's in Kuala Lumpur in Malaysia, and it's 2:00 in the morning now. But he said he will try. I hope
that's commitment.
I hope you're hearing.
Are there data on the impact of Xyrem or Xywave on ORP? From Derek Lowy.
Yeah. Xyrem, which is oxybate or gamma hydroxybutyrate. Yes, it does lower ORP for sure.
Okay. Have you had any data with cumulative sleep index and ORP histogram patterns in patients with shift work?
No.
Okay, so there's a whole other area. Rob Cohn is asking the fifth pentad of sleep fragmentation in narcolepsy 1 or narcolepsy 2, I would think have a higher ORP, where IH deeper sleep with higher ORP. I'm not quite sure what Rob is asking here, unless you can make sense of that.
No, I can't.
No, okay, that's fine. Mansour Ahmed, I think we're getting close to the end here, Amy. We may need to monitor and evaluate ORP, both sleep and wakefulness state, to get a better perspective of cause and effect relationship between sleep and wake symptoms. Any comments on what he said? I would agree. We have to spend more time looking at.
Yeah. I think. I mean, we are moving to try to use the ORP as to measure sleepiness. In other words, another test of excessive sleepiness rather than MSLT and maintenance of wakefulness and so on. And I measured in the 200 twins of Beck and Sam Kuna, when they spent 36 hours of full wakefulness, the period of deprivation, they monitored EEG awake, every 2 hours. And I have this data, and you can see that some people, as the deprivation progresses, they start getting sleep intrusions, like ORP drops all of a sudden to 1 or 0.5 for a few, 10, 12 seconds, and then they wake up again. Whereas other ones will just stay full awake the whole thing. So this is again the genetic difference between people who can who can survive sleep deprivation, the ones that should go on moon missions and that sort of thing, as opposed to slobs like me, which if you lose 1 hour of sleep, you're dead for the rest of the day. So I think this will be a very good test for occupational suitability for different
applications.
occupations, is monitoring ORP during wake. And
Yeah.
also for driving, and it's a very objective way of finding out how easy it is for you to fall asleep under normal conditions of stimuli, and
Right.
as opposed to being in a dark room and this sort of thing.
Yeah, and
Well,
I think it relates. There was also a comment on ORP as a measure of sleep depth, and looking, maybe cutting off the scores. But I think an important element of this is looking at ORP during wake to see, is there a potential for hyperarousal? So I think it's really important to include the full scale.
Yeah,
and you certainly have the tool to do that.
Yeah, we have to shut it down. David, I just want to apologize to David Rappaport. He had a question, but we do have to shut it down. And of course, you can fire the questions into Amy and she'll get them to Magdy and he will answer them. Thanks for the enthusiastic response. And of course, we'll do more. Thanks, Amy and Magdy.
Yeah.
Thank you.
Thank you, everyone, for attending. And thanks to our speakers, Dr. Younes and Dr. Samuels. And we'll keep you posted on the next one.
Thank you, Amy. Great show.
All right. Take care.
Thanks, Amy.
Bye.